All righty then. Well, welcome everybody. We've got a short presentation here, and I hope I've left plenty of time for questions. I'm sure there'll be some of that. Everybody is aware of what's been going on. We've all been living through this now for half a year. It was not unexpected. In 2016, I spoke at DDP and expressed my concerns over the discovery of a SARS-like virus. Remember, the SARS outbreak, the original one, was in 2003. And Peter Daszak and some others had been working over in Asia, sampling bats, and they were finding different types of coronavirus everywhere. The one that they found in 2014, SHCO14-CoV, was unusual because it was able to transmit directly to human cells, human lung cells in tissue culture. This is very worrying because jumping species like that for a virus is not a straightforward proposition. And what we normally see is that a virus will pass, let's say, from a rodent into another type of mammal, a cat or a dog or monkey, something like that. And it's a learning process for the virus. It's a slow adaptation to the point where if we go into an area and we see the same virus in two different species of mammal, we become very worried that it has a potential to jump into man. In this case, there was no intermediary animal. So quite worrying. And of course, the tissue cultures became widely infected and indicating that this virus was already well human adapted. So we were expecting something like this to occur for a while. Can I go to slide 2? Sometime in the time frame of September and October, an undefined respiratory disease broke out in China. And we're talking 2019. But there are some reports of sporadic outbreaks of an unusual respiratory disease that was lethal. It appeared to jump from place to place with a very low human-to-human transmission rate. Some of these infections were in healthcare workers. On 31st of December, the Wuhan seafood market cluster occurred. And eventually China would acknowledge that its first case was on the 17th of November, 2019. All during this time, from September, October, until 31st of December, China was busy buying up all the personal protective equipment, or PPE, from Australia and Europe, anywhere it could get its hands on it. It was buying the entire production of the 3M company, who had just built a massive new factory in China. So they were well aware of this before. Under international health regulations, China was required to inform the WHO anytime an unusual clustering of cases occurred. And they lied. China lied, and Americans died. Retrospectively, some people have gone back and looked at case descriptions of deaths, using the case descriptions to look at some deaths in California. And while it's not proven, there are some suggestions that possibly up to 9 deaths occurred in California before February 6th in the United States. Could we go to slide 3? China didn't inform the WHO of confirmed human-to-human transmission until 20th of January. This was the same time that we had the first recognized case in the United States, in Washington State. It was an American male who had traveled back from Wuhan, and a very intelligent man. And he was aware of the outbreak in China. And he started to develop a fever. And he went to a rapid care clinic. They put a mask on him. He had a temperature. And it turned out that he did have COVID-19. He was hospitalized the next day with shortness of breath. Chest x-ray was normal, regular PA chest x-ray. When they CAT scanned him, he had, with high definition, you could see some early ground glass appearing lesions, denoting interstitial edema. Shortness of breath developed. And he was given, I don't have the whole background as to how this happened, but he was given remdesivir, which was a nucleoside analog that had been tried during the West Africa Ebola crisis, 2014. And he recovered. He did very, very well. Within 3 days, his lung lesions had started to clear. In 4 days, his appetite was back. And he was fairly quickly discharged. On February 2nd, China banned all internal country air travel from city to Chinese city. It was all shut down. But they allowed their overseas travel to the U.S. and to Europe to continue. And I'm sorry, one can't help think that perhaps this was not intentional, because what it did was actually seed the world with COVID cases. Our first death in the United States occurred on February 6th, and this is roughly the same time that China started its own lockdown. Can we go to slide 4, please? Days late, $1 short, on February 25th, the U.S. Centers for Disease Control and Prevention announced for cities to prepare for outbreaks. Large gatherings were still occurring, including the Mardi Gras, and these all served to accelerate transmission. Under Chinese pressure, the WHO, although this all met the definitions of a pandemic by the WHO's own definition, they refused to declare it a pandemic until the 11th of March under Chinese influence. In the National Pandemic Plan for Influenza, updated in 2017, it makes a very clear distinction of what the federal government is responsible for, what each individual state is responsible for, and what the local authorities are responsible for. We'll go into this briefly a little later. But essentially, New York City had made no preparations. Their response quickly started to fall apart. There was a tremendous lack of personal protective equipment. The federal government was able to get donations from major U.S. companies and essentially UPS this stuff directly to the hospitals. We're talking about millions of items of PPE, masks, gloves, gowns, goggles, face shields. These were either shipped directly to the hospital and then eventually HHS took this over, and FEMA was brought in to do this. Although FEMA was never in the 2000 updated pandemic plan. And let's say they didn't work out too well. And eventually military logisticians had to be brought in to get the supplies to where they're going. The Javits Center was opened up as an alternate care site late, and the mayor, the governor, asked for the USNS Comfort hospital ship. It was in Norfolk at the time, uncrewed, and it was advised not to because the ship was not equipped to handle large numbers of contagious patients. Its main role is for trauma and providing normal internal medicine type stuff. So the ship sailed, it got up there, and it was to serve as an off-site alternate care site for non-infected patients. They were going to clear out the hospitals and put the normal patient load onto the ship and into an Army hospital, and that didn't work out very well. And the hospitals, number one, didn't want to lose their patients. So that was a lot of the overcrowding in the hallways and stuff. But eventually it got going. And there weren't enough testing kits to go around. And it didn't take long for a patient, supposedly non-infected, to infect the ship. And the crew became infected. So the ship got turned into a COVID hospital. Anyway, not that many patients went through it, and eventually it was deployed back to Norfolk. Could I have slide 5? So here we are at 15th August 2020 with an epidemic essentially still out of control in many areas. The dark red in this diagram, this is like Miami and some other places, are areas with 3,000 infections per 100,000 people. Slide 6, please. Transmission of the virus. We live in a world of microbes. They're everywhere. And we carry a great many of them in our bodies. If we could get rid of, let's say, Willie, and just vaporize Willie without touching any of the microorganisms, there'd be a shadow of Willie on the ground. We carry over 1.5 pounds of bacteria on our bodies. When we speak, there's enough kinetic energy in our exhalations to create a small particle aerosol. Now, granted, a lot of the particles fall out very quickly, but there's still a small number of 1 to 5 micron mass median diameter particles that linger and float in the eddies and currents around us. So if you're close enough to shake hands with somebody, the two of you are in each other's microbial cloud, which means you share microbes with your coworkers, your family members, the people you ride the train or bus with. These vary significantly from person to person. Children are very notorious for shedding microbes into the environment. And for some viral diseases, influenza and SARS-CoV-2 in our current pandemic, flatus can actually, the bottom picture is a thermal FLIR scan of somebody breaking wind. And there's actually, if this had been a young child, there would have been an infectious virus in that cloud. So this makes home nursing a little more problematic. Can I have slide 7? Of course, these microbial clouds, when they settle out, or you can have contaminated hands and you touch another object, you're transmitting virus to those surfaces. Most viruses don't last very long outside the body, but the coronaviruses as a whole seem to be able to linger on surfaces for a while and to stay infectious in an aerosol for a number of hours, which aids its transmission, of course. This guy on the left at the top of the picture, they had used a surrogate, a 1 to 5 micron sort of powder, and he'd been covered his hands with it and put him in a buffet. And turned out the lights, turned on the black light, and you can see everything that he touched and contaminated fluoresced green. And so, obviously the drinking glasses and utensils and this type of thing. The food server who comes along and clears up after him at the table also becomes contaminated. And if he manages to rub his eyes just once with a contaminated finger, within about 20 minutes at least, he could have live virus in his nose. The eyes constantly being bathed in tears and constantly draining away through the nasolacrimal duct, even if you're not crying. And experiments with humans have shown about 15 to 20 minutes. You can find markers inside nasal mucus. So what about masks? The problem is that in some studies, up to 40% of people, it's estimated, are asymptomatic. They carry the virus for a while, but and they transmit it through normal speaking or mucus droplets, but they don't realize that they're infected. At the top photograph of slide 8 shows an individual speaking normally, and this was taken with Schirlian photography, which is good at detecting pressure waves. And you can see all these thread-like pressure waves as he's speaking. If you wear a mask in a crowded area, it will reduce the chance that you could infect someone else if you were unknowingly infected. And you can see how the pressure wave stays closer in the bottom photograph, closer to his own head. These masks that have a one-way valve actually should be banned. They make it easier for the patient, but they're not, or the individual wearing it, but they're not suitable for protecting the public. And there's been one study where these neck gaiter devices, it's like a sock for your head, and you pull it up, and that didn't provide a lot of protection, and it became heavily contaminated. Can we go to slide 9? So the disease COVID-19, caused by SARS-CoV-2, presents with a wide disease spectrum. About 40% are asymptomatic with no symptoms. The rest of the infected individuals, it's a mixture. Some have very mild symptoms, maybe a very high temperature. They feel unwell, joint pain, muscle pain. They're very tired. This is all from a cytokine release, but they get better. Some may have very severe symptoms, including shortness of breath, which seems to be the dividing line between early infected patients and patients entering a more severe second stage of the disease. Some 15 out of 100 infections will be admitted to hospital. Some will progress to require intensive care. Some will need intubation, mechanical ventilation, and of those patients that are ventilated, we started out with 80% mortality, but that's now down to about 50% mortality with the addition of dexamethasone. Giving steroids to a patient is a tricky thing, as most of you know, so the timing has to be right. Could we go to slide 10, please? Patients at high risk are those with considered comorbidities, older age, high blood pressure, cardiovascular disease, chronic obstructive pulmonary disease, diabetes, obesity, and age. What's behind the obesity? That's still the subject of a little bit of research, but it may have something to do with Pickwinian syndrome and alveolar hypoventilation, and perhaps you exhale virus, but you inhale it back in. So that's still the subject of some research. But the elderly, 80 plus, do very badly. The younger patients, 70 to 79, are next. 60 to 69, 50 to 59. Next slide, please. 11. This is an outline from a number of patients that were aggregated. This serves as a very useful general timeline. You can see at the bottom bars that the COVID-19 is divided into two phases. It actually can be subdivided, but it's too complicated. There's an early disease phase, and this is really nothing more than a upper respiratory tract infection, like a really nasty head cold. About day 7 from first symptom onset, some patients, they enter a more severe late stage. And this begins with the development of a shortness of breath. This is an indication that they're developing SIRS, systemic inflammatory response syndrome. It's a microvascular inflammation in the capillary beds, and it can get quite progressive and start affecting the larger diameter arteries and veins. And it's associated with a microvascular thrombosis. This can start very, very early, roughly around day 8. You can see D-dimer circulating in the blood. Also at this time, you can start to see some troponin elevations. And right at this stage, right here, we can start to get an idea of your prognosis. You can see how critical it is, just the matter of a few days, 48 hours from admission to hospital, and you're starting microvascular thrombotic things in the lungs. So supplemental oxygen alone is not helping you that much. And within really 3 days from admission, you're in ICU and you're on a ventilator in some patients. At this stage, it's multiple organ dysfunction syndrome. The interstitial edema pulmonary edema gives way to acute adult respiratory distress syndrome around day 12. The early suggestions of cardiac injury on day 8, it becomes full wall injury. The virus doesn't appear to be replicating in the myocytes of the heart, but more in the macrophages that have invaded the heart. And we think it's the inflammatory cascade that these macrophages are triggering that actually damages the myocytes. So it's not unusual to start seeing a lot of arrhythmias and conduction defects, QT prolongation, this type of thing. And kidney injury. And this can progress to where the patient's on continuous flow dialysis and extracorporeal oxygenation, and death around day 19. Why some patients enter this, why some don't, is still a bit of a mystery. I think some of it is due to the amount of infective dose and of course the existing comorbidities in advancing age. But it's still not well defined yet. Can I go to slide 12? General symptoms. Loss of smell and taste seems to be one of the more common ones. About 90% in some studies of infected people show this. Fever, about 87.9% of patients will develop this. Dry hacking cough, and then just before the interstitial edema on day 7, 8, becomes very productive. Profound fatigue. The patients will tell you, I don't want to get out of bed. I've had it. Muscle and joint pain, sore throat, pharyngitis, headache in about 13.6% of patients. And we're seeing indications that there may be some degree of damage to the neurons. This thing appears to cross the blood-brain barrier. Chills, nausea or vomiting, about 5%, nasal congestion, 4.8%, diarrhea. The diarrhea usually occurs more towards entering the more severe phase of the disease. Can I have slide 13, please? So, the National Pandemic Plan was developed in 2005, President George Bush, and they spent a lot of time on this. It was developed from the Biological Weapons Improved Response Program, and the thought was if local communities could handle their own epidemic, then the nation would be able to handle a pandemic. And it set aside very clear functions of what everyone was supposed to do. The federal government was required to find an effective antiviral drug, move with all speed to develop a new vaccine, handle the financial aspects of this, like with the stimulus package and type of thing, and stockpile certain types of drugs and medical equipment, which they've done. Laboratory testing, if practical. Otherwise, if you did have an effective drug treatment, it would be treat on suspicion. And the goal was to treat early while the patients were still ambulatory and not on oxygen. And then the prophylaxis of high-risk populations, a universal mandate for social distancing, mask wearing, and education of the population. Honest education, what was going on. Can I have slide 14? So this is kind of a little diagram here, but to make it real easy, local authorities were the key, and they were required to do a couple things. There should be a helpline, a one number, a switchboard type thing, call in, where you can go with any question you have. And this would be operated ideally out of a building of opportunity that would be turned into a community health center, where there would be doctors and test supplies and outreach programs where small teams could go out to nursing homes, to stay-at homes, to elderly, this type of thing, supplying food and doing site visits, and making diagnoses and handing out the drug, teaching the parents how to keep from becoming infected themselves while they're nursing a child, this type of thing. In addition, the communities were to pick, again, buildings of opportunity. These have usually been high schools as alternate care sites. And they would decide whether they're going to move their hospital patients there or they're going to reserve those for the infected patients. And then they were required to have a reasonable medical stockpile. And then how they would distribute items that would come from the federal strategic national stockpile to a warehouse, how they would distribute that to their hospitals. A city would do this. Mayor de Blasio phoning, where are my things? Well, they're in your warehouse, sir. They were delivered 3 days ago. So obviously this thing wasn't rehearsed very well. Can I have slide 15? Thank you. Fortunately, a suitable drug was available. 2005, couple of the really great virologists in the generation before me were still at the CDC. And they were working on SARS, and they found that chloroquine seemed to inhibit viral replication. It was a well-understood drug. The Chinese and the Koreans had read the same article. And by early, mid, and late February, there was a significant amount of data and trials emerging from South Korea, China, and France concerning the early use of hydroxychloroquine and chloroquine. And it was fairly early on, it was realized that the early outpatient use of this drug could actually prevent COVID-infected patients from progressing from the early stage into the more lethal late stage of infection. These patients still got sick, but most avoided hospitalization, and if they were hospitalized, the majority stayed out of intensive care and off of mechanical ventilation. As a bonus, the drug was already FDA approved. It had shown itself to be a remarkably safe drug after 55 years of use. Some of its alternate use, it's an anti-malarial drug, but It's also used in some connective tissue disorders. So, I mean, this seemed like a gift from heaven. Could I have slide 16? Almost immediately, there started to be a pushback from Dr. Fauci, who is head of the National Institute of Allergy and Infectious Diseases at the NIH, who described a lot of this very well done research as being only anecdotal, stating that the gold standard was double-blind, randomized studies, clinical trials, which seriously is a load of nonsense. You look at all types, you look at observational, you look at epidemiological, you look at all types of studies, not just limited. And these randomized clinical trials, and I can give you firsthand experience going through these and looking at them, a great deal of them are complete rubbish. And once you get the statisticians involved, you can actually have studies that don't look like they do anything hidden when the drug actually is doing something, but may not quite be statistically significant because the sample size is too small. So this pushback was only going to get much worse. Nobody could understand why this was happening. But what is, without a doubt, is that this is not the actions of a scientist who's supposed to be providing the leadership of this country with the best information to control the pandemic. And, you know, I don't like speaking out, but the entire task force that was established really didn't seem up to the task. Can I have slide 17? The head of the coronavirus task force was a lawyer and is a lawyer and a drug company executive, Alex Azar. No medical or public health background. His chief of staff, a very nice guy, Brian Harrison. But his job before this, he raised labradoodles, the dogs, little furry dogs. Well, some are big. No medical or public health background. Dr. Fauci seemed to sort of take the lead with things. And Dr. Deborah Birx was brought in, very experienced during the HIV, ex-colonel in the military, but being experienced with a slow-moving thing like HIV is not quite the same as a rapidly expanding upper respiratory tract and then lower respiratory tract disease. Dr. Renfield was ideal, colonel in the military, infectious disease experience, tropical medicine experience, virology experience, but I think he got blamed for the CDC testing fiasco, which was not his fault. It was not his fault, but you're head of CDC, so you take responsibility. Anyway, and various cast of characters would come in and out of the task force as the need arose. One of these was FDA Commissioner Stephen Hahn, very intelligent man, 2 medical specialties, oncology and radiotherapy. But he was already failing the United States with respect to the lateral flow assays. These are the quick immunological, like pregnancy test kits you can buy at CVS. And when it became necessary for a rapid increase in testing, they just opened the floodgates. There was no quality control. The Chinese, there were 120 companies, I think, in the end, just shipping rubbish over here with less than 50% accuracy. You could throw a coin into it as well. Very high number of false positives. And if you're trying to do back to work and you've got somebody with one of these assays you determine has antibodies and it's safe to go back to work and it's a false positive, it's not acceptable. Millions of dollars were wasted by companies and healthcare facilities, pharmacies offering these things. And it was like pulling teeth to find one of these things that actually worked correctly. And both the PCR and lateral flow assay testing is still a mess. I've had reports now from 4 different states of people waiting in line to get their swab and PCR test, fill out all the paperwork. After an hour, they're tired of waiting in line, so they leave. They hand their papers in. Never give a swab sample, and a week later get back a report that says they're COVID positive. So something's very, very wrong here. And these are reputable people, I believe them. We're on slide 19 now. Slide 20. So anyway, through various mechanisms, the United States managed to acquire a significant amount of hydroxychloroquine very early on. Now the FDA becomes involved. The mechanism they used was to insist on an EUA for any hydroxychloroquine issued from the Strategic National Stockpile. Now, that was not all they're doing, without getting into it any deeper. But they agreed to do this. So they issued this EUA for hydroxychloroquine on 28th of March. Again, it was already FDA approved. The doses that were being given for COVID were equivalent to rheumatoid arthritis or systemic lupus erythematosus. And private physicians have been prescribing it successfully for quite a while for their COVID patients, getting it through Cardinal and the other distributors. I think its cost was roughly about 60 cents a tablet. There was a slight hiccup for about 7 days where it was a little difficult to get, but there's millions of tablets now in the national stockpile. That only lasted about a week. Slide 21, please. But rather than simply condone its use for COVID in outpatients, which was what was needed, that's how you control the epidemic, the pandemic. The FDA grossly overreached the available clinical trial data, and they started promoting the use of it for patients in the hospital. Their EUA even stated that hospitalized patients were likely to have a greater prospect of benefit compared to ambulatory patients with mild illness. Well, that's not what the data showed to date. In fact, the data show that just the opposite was true. Hospitalized patients were typically ones with shortness of breath. That took them to hospital. And they're in various graded later stages of COVID infection, multitude of different pathophysiologies going on. By the time they actually got their test and actually got given the hydroxychloroquine, they were well established into systemic inflammatory response syndrome, troponin elevations, and all sorts of stuff going on. There was little data, although there was a little bit of encouraging data, but little data on hydroxychloroquine to suggest anything that would reaffirm the FDA statement that late-phase hospitalized patients would have the most benefit from hydroxychloroquine. Can I have slide 22, please? We were trying to, some studies needed to be done, and the perfect laboratory there were two. One was a cruise ship that nobody would let dock in Japan. And the other one was a USS Roosevelt aircraft carrier. It had docked somewhere, I think maybe Vietnam. And some sailors got infection. They brought it back on board. Unfortunately, we couldn't move quick enough for either one of these to get any sort of, it was a perfect laboratory for prophylaxis and for early treatment. Now, we had the fit young people on board the aircraft carrier, and we had the older patients on the cruise ship. So, I mean, anyway, we learned valuable lessons for the future. Can I have slide 23? About this time, a series of 2 negative research papers out of 26 positive papers for hydroxychloroquine use got published on the MedRxiv server. This is a posting site. These papers aren't peer reviewed. And in fact, I think it's still there. There used to be a warning. Media, do not read this. These haven't been peer reviewed. They're just being posted. One was a VA study where the doctors involved, it was a retrospective study going back through records. And they picked out the patients that were in the worst clinical shape with multiple comorbidities, cancer, a couple HIV patients, cardiovascular disease. These patients were already dying when they were given hydroxychloroquine. And then a Brazil study where somebody forgot to carry a decimal point, and patients were given lethal doses of chloroquine, and 12 died. So again, highly refuted. I mean, the VA study was debunked almost immediately. The Brazilian study, the doctors that are involved have been indicted, and JAMA Open so far has refused to retract the paper. But what all this massive press did, and Neil Cavuto screaming, "Don't take chloroquine, it will kill you," and this type of thing, the recruitment for some outpatient trials, early outpatient trials, and early hospital use trials, like the minute you hit the emergency room, you're given hydroxychloroquine and azithromycin. You can see the graph. These fell apart. The FDA didn't do due diligence when they looked at these. Both studies looked. It only took a few minutes to see what was wrong with them, but they sent out a black label warning about a week later, and recruitment just got worse and worse. They had no data at all about outpatient use of hydroxychloroquine. They lumped COVID as one disease rather than differing pathophysiologies between early and late. They seem to have no recognition of the literature showing you could get mild troponin elevations on day 4 of COVID infection, and that about 20% or a little higher of COVID patients really had detectable elevations of troponin, significant, and some were developing, heart damage. Patients not taking chloroquine were showing arrhythmias and QT prolongation. The FDA only reviewed inpatient data, but in its warning there, it says not to use it outside of a hospital setting. And the press went wild again, and everybody's scared of it now. And doctors are afraid to prescribe it. Pharmacy boards won't allow it. Medical boards won't allow it. I think there's only 4, now 5 states where doctors are actually free to prescribe it. I talked to the head of community medicine yesterday in Texas Tech, and he's convinced it kills you. So, there you go. So, one of the safest drugs in the world, taking hydroxychloroquine with an early COVID infection is no worse than taking it if you have the common cold. A recent paper just came out in Journal of Electrophysiology showing absolutely no baseline change in QT throughout the course of early patients before, still ambulatory, before shortness of breath, no deviation from their baseline ECG when they started the course. Could I have slide 25? Anyway, there's about 4 papers that came out. 2 have been from Bullware, and this author has, for some reason, used statistics that actually his papers show that hydroxychloroquine actually does do something in early prophylaxis and early post-exposure treatment. The sample size is a bit too small to bring it out. But it was labeled no effect for pre-exposure, no effect for post-exposure treatment. The press went nuts again. And you can see what's happened to patient recruitment for legitimate early use outpatient, aggressive community outpatient use of hydroxychloroquine. And then, finally the FDA recalled the emergency use authorization. Slide 25. Can I have slide 26? So basically, the Fauci Hahn doctrine was for you to get tested, which may take a week, quarantine yourself at home until you're so ill with shortness of breath that you have to come to hospital to receive a drug that may not work because you're so ill. It's ridiculous. There's absolutely no scientific grounds to try to extrapolate from inpatient data that the applicability of hydroxychloroquine for outpatients. And I'm sorry, but there's no other conclusion that can be made except the FDA has been carrying on a campaign of lying to the American public throughout this whole pandemic. I firmly believe that now. Some things I can't discuss. But hydroxychloroquine has been used aggressively in outpatients, ambulatory, not requiring supplemental oxygen, 1 or less visible lesions on PA, chest X-ray, ground glass. So what are these countries, what does their data look like? Could I have slide 27? I don't have all the countries on here because, it's very complicated. But there's about 10 countries now that have aggressively used hydroxychloroquine, aggressive programs, aggressive prophylaxis use, aggressive early treatment use. India has 1.2 billion people. Now they're getting a second surge now, but a couple of weeks ago they only had 38,000 infected. And they had cases fairly early on. The USA and the UK have followed the same sort of doctrine. And you can see their demographically adjusted deaths per million. So the drug's doing something. When you look at the FDA EUA recall, the letter was written to BARDA, and a number of us went through this very carefully, and there's nothing in there. It's that whole letter is rubbish. I mean, it's false. They said, well, it doesn't help viral clearance. Well, you don't measure viral clearance with PCR swabs. You know, you've had microvascular clots, you've got dead virus trapped in there, the clots are being resolved, you've got PCR fragments in your bloodstream, or your urine, or your stool. That's not the same as live virus. To determine viral clearance, you want to culture live virus. That is the gold standard. So you can't be saying in your paper prolonged viral clearance unless you've done tissue culture and plaque assays. There was some other, I mean, I get upset every time I talk about it. Can I have slide 28, please? This is the current treatment algorithm. And as long as your patient's carefully reviewed, elderly patients carefully reviewed, and their drug history that they're using carefully gone through, this is what the guys at Baylor, very well-known heart center, have recommended. If you need a copy of this, I'm sure Jeremy can send you this slide. So we have a new face mask that looks like it may be useful for calming the fear of COVID-19. And I'm ready for any questions that you might have. Zinc is an interesting addition. The hydroxychloroquine is an ionophore. That means it can pull zinc into the cell, into the lysosome, and we believe that zinc inhibits viral replication. This has been shown in tissue culture. Most protocols are adding this. If you go back to slide 28, I think there's some zinc on there. Zinc lozenges 5 times a day, or zinc sulfate tablets, 220 milligrams, 4 times a day for 5 days. So Dr. Zelenko and some others swear by this. I think its most use would be if somebody was zinc deficient. But I don't think it's going to hurt. And it could do some good. Does that answer the question? Okay, and enjoy the conference. Hi to everybody.